I discussed the role of induction chemotherapy and concurrent chemoradiation in treating unresectable cancers of the head and neck. The appropriate incorporation of chemotherapy as the first modality in delivery of care for patients whose tumors can't be removed with an operation. I made additional discussion of cancers of the oral cavity per se, because while this meeting does incorporate the head and neck, the primary focus is oral cavity tumors. Well, what I did was review some of the results of randomized trials as well as large experiences that don't really reflect randomized design that demonstrate an important role for induction therapy and concurrent chemoradiation in cancers of the head and neck that can't be removed, and discussed some interesting new results coming from South Asia, where they have defined formal criteria for tumors that cannot be removed with an operation, and shown that one can shrink them if you use chemotherapy as the original modality or the initial modality, and in a substantial minority of patients follow that with an operation, which may even prove curative. I think that the best validated approach for tumors that cannot be removed has been to give chemotherapy as the initial modality and follow it by radiation, either radiation by itself or radiation with the addition of concurrent chemotherapy. When you ask what needs to change, I'm not sure something does need to change, at least in the absence of trial data comparing approaches to find whether tumors that can't be removed are better addressed with an operation or radiation as the primary modality. They're important for all patients. Traditionally, doctors have worried more about survivorship, and patients identify survivorship as what's most important to them. But they're certainly disconcerted and often unhappy if we can't afford a good quality of life. It should never be far removed from our thinking when we're about to offer a patient an operation. You know, some of the side effects of treatment that don't involve operation, such as radiation with curative intent, also may have adverse effects on quality of life, and it's incumbent on all members of the multidisciplinary team to address quality of life, and not just quality of life, but function, because they may be different for patients before initiating therapy, and to do our best in the course of treatment and follow-up to assure good function for patients. I guess the key point of my talk really would be that if you're going to care for patients with advanced malignancy, even more than in limited stage disease, it's important to have a functioning multidisciplinary team composed of head and neck surgical oncologists, radiation oncologists, medical oncologists, reconstructive surgeons, and members of adjunctive subspecialties such as dentistry, speech-language pathology, rehab, and a close working relationship with many other medical specialties. Some of what I've done in the last few years has involved support for the National Cancer Institute's Head and Neck Steering Committee, and the National Cancer Institute's global health initiatives are helping to support an intercontinental research group that we're trying to establish to permit worldwide collaboration for head and neck oncology. Now, Australia and the US are already continents. International collaboration in Europe has been quite common and well established, but we don't do as well in an intercontinental venue, and I think that's important, particularly so as we better understand the disease and identify smaller and smaller populations for specific targeted therapies.